Thank you for joining me today to talk about hypertrophic pyloric stenosis and the sonographic feature of hypertrophic pyloric stenosis. The question at this point here that comes in there, okay, so what is this pylorus? Uh, so uh, let's talk about this normal pylorus first before we get into hypertrophic pyloric stenosis. The pylorus is a mobile tubular structure joining the duodenum to the stomach. So that's really the connection between the duodenum and the stomach. It doesn't have a muscle, which is circular muscle we refer to as the pyloric sphincter. It's highly important for us as we are thinking of this diagnosis. We need to understand the normal findings about this pylorus. Usually, that muscle that I just talked about that circular muscle, measures less than 3 millimeter in thickness. The canal length tends to be less than 14 millimeters. The pyloric volume is less than 1.5 cc, and the transverse diameter of the pylorus is less than 13 millimeters. These actually are very important in the diagnostic process. Surely there are many of things. If you come to ask me, what are the most prevailing or the most diagnostic tools out of all of those, it tends to be the muscle thickness and the canal length of the pylorus tend to be really those I would say on the top of the list in terms of diagnosing pyloric stenosis. So if you come in and take a look at the pylorus, just to give you an idea what it is, this is the area I'm talking the stomach. You get the duodenum, and this is where the actually the pylorus is. These are the muscles that we're talking about, and that's what you have. So this canal is very important to watch, which is later I will talk about in the diagnosis, because you can see the fluid coming and leaving the stomach and going into the duodenum through this canal. Now, the question that comes in is very often what I really say to people, okay, find the pylorus. Where is it? We're not gonna go and fish in there. I mean, this is not a fishing actually a game here. You gotta at least use landmarks to find that pylorus. The best way to do it is find the gallbladder, and usually that pylorus sits almost like posterior and medial to that of the gallbladder, and that's exactly what you see. That's where the stomach. This is the duodenum. Pylorus is going to be this area. So this is really a landmark, a good landmark, or something good to use as you start to try to locate that pylorus. Hoping this is helpful. I'm hoping that now you understand what the pylorus is. I'm hoping that you also understand the different measurements, the different criteria of a normal pylorus, because now we're going to move on to this the disease process of the pylorus, and which I said earlier referred to as hypertrophic pyloric stenosis, or referred to as HPS. Very often, many of us leave the hypertrophic out of the way. We'll just say pyloric stenosis. So what is that? If you look at the picture down here in this diagram, you see that little tiny muscle that I showed you earlier now is becoming more elongated and thicker. And that's what it is. So it's really the thickening and elongation of the pyloric muscle. And of course, the mucosa. And that's all of that stuff. When you have this thickening and when you have this elongation, what it does do, it leads to the narrowing of the pyloric canal. And that's exactly what happens. It will not allow the fluid and the food to go through that canal. And so at the end of it, when it's not going to allow it, means it's going to be leading to gastric outlet obstruction. And that's again goes with some of the symptoms that we'll talk about a little bit later. When you look at pylorus stenosis, usually the incidence of it is around 3 in 1,000 cases, affects more males than females, 4-to-1 ratio. It's more common in the firstborn white males. It has also been reported that children with type B and O blood are at high risk. The children of mothers with previous HPS are also at high risk. So if you come in to take a look at it, one, it's really seen, usually seen by between the ages of 3 and 12 weeks, with a peak incidence around the fourth week of actually uh, post birth. So that's what you got in there. So it's around 95% of the cases. So what are those symptoms? Again, we are talking about symptoms of this disease and that disease, and causes and so forth. So what are, before I talk about the symptoms that the patients present with, what are the causes? What are the etiologies of hypertrophic pyloric stenosis? Again, it's idiopathic. It's very tough. It's a very high percentage. We do not know where they occur, but we also understand that this hypertrophic pyloric stenosis is associated with prostaglandin, which found, I mean, this is found to induce enteral mucosal hyperplasia, eosinophilic gastroenteritis, Apert syndrome, trisomy 18, Cornelia de Lange syndrome, hypergastronemia, and nasoenteric tubes. Also, what we found that it has been reported that oral erythromycin intake by mothers during pregnancy, breastfeeding, or by given to children to treat pertussis post-exposure prophylaxis has also been linked to hypertrophic pyloric stenosis. So there's several, and these are some of the causes of pyloric stenosis. So now, what are those presentation? What are the symptoms patients present with as you and I see them? As we see them. Usually, when we're looking there, if you come in, I said earlier about the number of week one pyloric stenosis present itself. I said only few weeks after birth. The classic presentation of hypertrophic pyloric stenosis is intermittent projectile vomiting. Parents will always say, that I feed the baby, and all of a sudden, the baby vomits, and things come in like almost like they shoot out like a projectile. And that's exactly what we look into. And then usually this type of vomiting, projectile vomiting post feeding, tends to be non-bilious. Another finding is the palpation of an olive or walnut shaped mass on physical examination. Again, dependent on the patient's body habitus, but that's again part of the presentation that we have. Also, some studies have shown that the palpation of this mass, this olive or walnut shaped mass, might not be possible in infants younger than 21 days old. So an increase also in peristalsis. Increase in peristalsis, that's another one that we also see with hypertrophic pyloric stenosis. Other symptoms like dehydration, electrolyte imbalance, alkalosis, unconjugated bilirubin, and eventually weight loss can also be seen with those patients. So now let's get to the midst of it. Let's get to the real thing. How do we diagnose pyloric stenosis on ultrasound? Oh yes, this is actually the bread and butter. This is what we need to pay attention to. Dependent on the patient's body habits, very often in this type of population, we tend to use very high frequency transducers, linear array transducers, 5 to 12 megahertz. And again, look at the patient's body habits, and then you can determine the frequency. I always recommend to use systemic approaches to scanning. When you are doing ultrasound exam, you just don't want to be going back and forth in every direction with no goal in mind. So the systemic approach can help. Number one, identify the pylorus. Do you know where the pylorus is? I just told you earlier, use the gallbladder as a landmark. It's posterior medial to it. Number one, try to identify the pylorus, even though it's tiny, but look at that. Number two, the second step is observe the pyloric morphology. What I mean by pyloric morphology is look at the muscle. The pyloric muscles is hypoechoic. The pyloric mucosa is hyperechoic. Target sign, donut sign, usually in the transverse plane. This is about morphology. Does this pylorus have a cervix sign? and also in sagittal plane. For many of us who scan and do ultrasound, GYN ultrasound, you understand. Also, we understand what that sign is, but that's exactly what it is. It looks like a cervix, a uterine cervix. Number three step is to observe the behavior of the pylorus. This is actually one of the major advantages of ultrasound is its the dynamic nature. We can see things moving. We can see things actually the fluid moving back and forth. I mean, this is what's important and why this actually imaging modality is actually great in observing and also diagnosing hypertrophic pyloric stenosis. So that's why we keep that in mind. As a matter of fact, the sensitivity of ultrasound in the diagnostic process for actually pyloric stenosis tends to be nearly 100%. I don't want to say it's really truly replacing the upper GIs, but I would say it's there. It's really in many situations it is, and that's why and that's it's becoming. I would say that in there the accuracy in the diagnosis and the patient outcome, it's amazing what ultrasound can do in this situation. So would I say ultrasound is becoming the actually the procedure of choice for the detection of pyloric stenosis? Oh, for sure, I would say that this is actually what we have seen. Now, so we talk about the first three steps. Number one, identify the pylorus. Look at the pyloric morphology, and at the same time, the pyloric behavior. And also, you can do Doppler. I mean, yes, I do Doppler. Usually, there's not much flow in the normal primary pylorus, but when you have a pyloric stenosis, some of that change, even though we do not utilize it very heavily, but that's something important to get used to. So definitely that's in there. So let me show you some images there that can help you and help me understand what I've been talking about. Number one, when you look at it, when you are practically looking at the stomach, this is the stomach coming closer to the antrum of the stomach. Here, what you do is see where the pylorus is going to come in. It's a little tiny, sure, I understand. And usually, what you do, you want to watch the duodenum is going to be somewhere here, and that's what you want to see. You see the movement of fluid going through the pylorus into there from the stomach to the duodenum. So it's good to watch this area. Here, you can see the stomach filled with some um, food or fluid in there. This is where the pylorus is. This little tiny one area, the duodenum down here, but you can see the pylorus sitting there. Now, when I look at that, this is under normal condition. So we see that normally. Now, when I come and look at this, I'm like, whoa, what's going on here? I can see this probably this around this whole thing. And that's where the pylorus is. This pylorus that was little tiny down here, now it's becoming big, very thick. The muscle is thick. If the muscle down here is very tiny, like there, now the muscle is thick. The mucosa is thick and more echogenic. Now you can say that this is not normally looking. It looks like a cervix, as a matter of fact, uterine cervix. So there's some fluid in the stomach. So that's again, this is the typical appearance of pyloric stenosis. Surely I'm leaving the pitfalls away, but that's something that you have to pay attention to. So let's see this one here, and then I just want you to watch a little bit down here. You can see some of that stuff moving again from the stomach through the pylorus towards the duodenum. So again, replay it again. You can see that's what you need to watch. That's what I'm talking about, the dynamic nature of ultrasound. That's one in there. So again, there are things that you have to watch for. Surely when you go transversely, it looks like a donut sign, like a target sign. That's what you see. See, the muscle is very thick, hypoechoic. That's where the mucosa is inside the lumen there. But that's what you want to watch out for. This is actually important. In addition to that, this is coming back to the cervix sign. So now what happened in there really with actually pyloric stenosis, what you're looking for is this. Now you see the mucosa becomes more hyperechoic. You see the muscle, this hypoechoic, thickened. So like you're going like there. Earlier, I talked to you a little bit. I said in there that usually the muscle is less than 3 millimeters. So now you measure it. Surely this is more than 3 millimeter. Now what you do, you have to look at also what is important to avoid the misdiagnosis. What you want to do, you need to ensure that you are symmetrical. When you are on it, if you are perpendicular on it, make sure you got your muscles symmetrical. Both muscles are almost the same, look the same. You don't want to have that. This okay. I understand the muscles are actually here thickened. I mean, no one can doubt it, but there's no symmetry here. I mean, very muscles asymmetrical. Just some rotation of the transducer, you will be able to elongate it. and you have a beautifully looking actually pyloric. Practically, that's why pyloric stenosis, right, in this situation. So that's in there. I want to do that. So now what do we do? Some, again, some more of the tricks that's coming in. I talked about the symmetry and all of that stuff. The recommendation is that, no, with the air in the stomach, air is the enemy of ultrasound. So what you want to do, you want to distend the stomach. Very often, the caution that I have for you, do not over distend the stomach. The minute you over distend the stomach, look what happens to the pylorus. It gets pushed posterior or distally away, and really it makes it very difficult to actually evaluate it. So make sure that, okay, fill up the stomach, but do not over distend it. In addition to that, I mean, the recommendation, either you can give them water or you can give them sugar water. Let's like don't stay away from milk, because milk can be very, because it causes shadowing and some other artifacts which you do not want to do. You don't want to do that. So that's what it is. Very often, I mean, the recommendation, you gotta watch it for some time. Don't just do it that way. Oh, I'm done. No, I mean, you gotta probably scan it for around, at least around 20 minutes. Watch it for 20 minutes. If it's gonna change or it's not gonna change, that's something important. So don't do that couple minutes, 3 minutes, and it's done. Even though sometimes it's right there. I mean, you diagnose it, you see it, it's very typical features of pyloric stenosis. But make sure, give yourself some time to ensure that the patient does not have something else. The patient, may have pylospasm or some other things. So make sure you do that, and it's recommended to at least give it at least 20 minutes, and watch it for that, to watch the fluid going in and out, actually out of the stomach to the duodenum. This is important. Another thing what also can be very helpful. Let's assume you give the patient water, and then now the stomach is over distended, or the patients already came in with over distended stomach. What do you do? Roll them. It's okay to roll the patient. You can put them in a left lateral decubitus or left posterior oblique position. Just make sure that, because that will move the fluid away and then bring the pylorus back up. If you want to see the fluid moving from the stomach through practically the pylorus to the duodenum, roll them in a right lateral decubitus or right posterior oblique position, because that's going to allow the fluid to go. It's going to be gravity dependent. So these things can be very helpful to you and I as we scan, because otherwise, I mean, if we don't have most of these maneuvers, it will make our life miserable, because that we're not going to be able to make the proper diagnosis. And if all of that fail, your patient can do some in some situation, you may do what we call a nasogastric tube, place it in there and distend the stomach. But many of the patients I have done and I've dealt with, I mean, we were able to actually go ahead and give them the sugar water, and the sugar water, they love it. They love it. It's like it calms them down. But again, that these are some of the tips that you can use, or maneuvers or tricks that can help you diagnose this pyloric stenosis. So now let's say, even though I mentioned some of that earlier, so what are some of the feature of hypertrophic pyloric stenosis? Well, number one, the AP diameter of practically the AP diameter of the pylorus is greater than 13 millimeter. The length of the canal is important. So now it becomes elongated. It will be more than 14 millimeters. At the same time, the thickness of the muscle is important, and here is more than 3 millimeters. So you see those things actually. Uh, I mean, there's much agreement about these numbers, even though there's some variation. Some places may use that the length slightly higher or so. The gray zone is there, but those are good numbers to actually to follow and use in the diagnosis of pyloric stenosis. But when you see it, by the way, if you see it, you cannot miss it. It's just right sitting there. It's just in front of you. So these are some. Now, what are some other things we look forward for? Well, if you're looking in there, look for the movement, the peristalsis within the stomach. Sometimes what happens when there's poor emptying, or there's some stenosis, now you see this the hyperperistalsis in the stomach taking place. So almost like you see the fluid with this molecules in there, water molecule, what have you. They're almost like moving, like almost like a snowstorm inside the stomach. So that means something preventing them from actually continuing their path through the pylorus. Also, sometimes what we call it the double internal layer of the crowded mucosa. you see that the mucosa is sticking into the stomach. It looks like a nipple. We call it a nipple sign. That's also there, and the flow in the pyloric area tends to be increased. But that's why. So the hallmark, the things that really we use the majority of time is really truly the length of the pylorus, and also the muscle thickness. Those are actually very important features that we rely on. So having said that, let's take quick pictures. I showed you a couple images in there, but you can see again here the stomach fluid in the stomach. You see the pyloric muscle here and here. They are very thickened. That's how you measure it from here all the way down. This is what you measure it, more than 3 millimeters. This is the mucosa. This is mucosa more acogenic, and I measure the length of it. Usually it's more than 14 millimeters. Some people say 14 millimeter equal or greater than 14 millimeter. So that's big enough. And here again, another one, she's some fluid. That's why we always say stay away from milk or something, because that milk could cause shadowing or practically other artifacts. But again, you can see the pylorus here, which is very thickened as well. The muscles thickened, the mucosa probably elongated. Look at it. This is what you see, and there's some food particles in there. But again, you put your color Doppler, you see some flow. Usually, you don't see much flow in the pylorus. I just wanted to show you one more, at least another picture of this pyloric. So let me just go back in here. Let me just show you this, and how when you distend it, over distend the stomach. See, this is how it pushes, starts to push the pylorus more distally or posteriorly, and good luck. It's really hard to evaluate. But I want you to see here a little bit, even though it's not very evident in this, I want you to see here how the fluid starts to actually, it's trying to go through the pylorus to the duodenum snot, but it starts to back up. See, coming back, see how it's going backwards, and here starts to swear, slightly swear, like almost like a snowstorm, and you see it moving. Maybe at this time, got out of the way because that fluid may be coming back out of the mouth in a projectile way. So I've had some patients do that. Sometimes scanning them, all of a sudden, like, you can see that coming out of their stomach. It goes for a distance. So keep away, stay away. And that's why when you see that, because that should be coming. Now I'm gonna put a picture here for you at the couple images to show you, and then I'm gonna make you make the call. I'll give you a couple here to take a look at that, but I'll guide you through it. This is the first thing you try. You locate the pylorus. It's great, beautiful, and all of a sudden, woo, you see this, and you say to yourself, "What is that?" It's like, this is thickened, or what's going on in this situation? So you wait, and they are saying, immediately in your head, it's typical up here. Oh, this is pyloric stenosis. Well, if you do that and you just walk away, then you are in trouble, because I said earlier, at least give it at least 20 minutes to make sure that everything goes in there. So as you scan, now as you watch and wait and see and behave, see how this is going to behave, you can see now, watch this. You're still going to move them. And now you see some movement of this area that was very thickened looking in there. Surely the patient have some symptoms, but again, you can't just always zone. So more of that. Now you can see the fluid more going in, and as you see, there's something in there that almost like moving through. So in this situation, just to let you know, and we started in the beginning that way, but then at the end, you can see the fluid in the duodenum. This doesn't exist anymore. This bracket thickening that we saw before, what didn't exist. So in this situation, this patient was diagnosed with pyloric spasm. So it wasn't really pyloric stenosis, it was pyloric spasm. I just want to make sure to bring that to your attention. Do not make a swift decision based on one image, but take your time, ensure that you apply all the things we talked about here, and I guarantee you will not miss pyloric stenosis. You will not miss it. This is exactly what we are. We love this. So having said that, I really thank you so much for your kind attention. And as I said, sonography rocks, and I'm very proud to be one of you. Thank you so much again.